Hello, everybody. Welcome to the seventh session of Meet the Expert webinars. I will give the floor to Professor Peter Morozov, who is Vice President of the World Psychiatric Association, to address the event. Peter.
Well, thank you, Kostas. Good evening. First of all, I would like to say that I'm representing World Psychiatric Association here in the absence of the president, Dr. Afzal Javed, who is now on duty travel, and I'm Secretary General, not Vice President or something like that. I'm Secretary General, and I'm very, very happy that I have a chance to introduce you the webinar Meet the Expert number 7. You will have today a very, very interesting topics and very distinguished, very famous lecture. And I pass the word to our moderator, Professor Konstantinos Fontolakis, who is in the origin of organization of this series of webinars. He's from Aristotle University in Greece. And I think this is a very, very important event and became very famous now event. And I'm sure that the audience is waiting for our speakers. Please, Konstantinos.
Thank you, Peter. We will start with our first speaker, who is Professor Myrna Weissman. She will talk on interpersonal psychotherapy, a global reach. To start with, who is she? She is the person behind IPT, and IPT is one of the most recognized and acceptable and effective psychotherapies used today internationally. She received a PhD in epidemiology from Yale University School of Medicine in 1974. Her research is on understanding the rates and risks of mood disorders in families using methods of epidemiology, genetics, neuroimaging, and the application of these findings to develop and test empirically treatments and preventing interventions. Her current interests is in bringing psychiatric epidemiology closer to the translational studies in neuroscience and genetics, and on using electronic health records for research. She directs a 3-generation study of families at high and low risk for depression who have been studied clinically for nearly 40 years and who have participated in genetic and imaging studies. She directed a multi-center study to determine the impact of maternal remission from depression on offspring. She was one of the primary investigators in a multi-center study to find biomarkers of response to the treatment of depression. Along with her late husband, Gerald Kellerman, she developed interpersonal psychotherapy, an evidence-based treatment for depression, now with over 140 clinical trials translated into numerous languages and recommended by the WHO and the US Preventive Task Force of Perinatal Depression as one of the evidence-based psychotherapy. In 2009, she was selected by the American College of Epidemiology as one of 10 epidemiologists in the United States who has had a major impact on public policy and health. The summary of her work on depression appears in a special issue of the Annals of Epidemiology, Triumphs in Epidemiology, in April 2009. In 2016, she was listed as one of the 100 highly cited authors according to Google Scholar Citations with Age Index of 182. In 2020, she received the Brain and Behavioral Partners Humanitarian Award. In 2021, she received the Research Award from the American Psychiatric Association. So her speech today will be on interpersonal psychotherapy, a global reach. Professor Weissman, the floor is yours.
Well, I am so pleased to be part of this series organized by you, Dr. Fontolakis, and also to be encouraged to speak about IPT. With that long introduction that you gave about me, I want to assure you, I'm going to tell you a story today and not a lot of figures and tables. I'm going to tell you how IPT was developed, whether it works, its efficacy, how it's used, and the new introductions of its use globally. And it's a very personal story, as you'll soon see. First, the background. In 1960s, it was a very different scene for the treatment of depression. Medications for depression were being widely used. Rating scales were being developed to test these new drugs and make sure they worked. And also the FDA was established to determine whether medications had proof of efficacy. And these were the new laws that were required, at least in the United States. Most patients received outpatient care and were not hospitalized. That is the situation in the United States. This was the reality. The reality was that psychotherapy in practice was the most common treatment. The conventional wisdom was that you couldn't test psychotherapy. And Eysenck, who was a very accomplished, distinguished psychologist, based on 7,000 case studies of psychoanalysis or psychotherapy, concluded that there was no evidence that psychotherapy worked. Of course, there weren't clinical trials, but he reviewed the data. So there was a real gap between the new medications, the new rating scales, the new laws, practice that was psychotherapy, and the reality and the belief that psychotherapy didn't work. And if it did, you couldn't test it anyway. It was against that background, on the next slide, that the innovators came. And the innovators were Aaron Beck in Philadelphia and Gerald Claremont in New Haven at Yale. And they transformed the research and practice of psychotherapy. Beck was influenced by cognitive psychologists, and he was way ahead of Jerry in developing and trying to manualize what he was learning from the psychologists. Jerry was running the first multi-site clinical trial of medications, and he felt that he had to include psychotherapy as a milieu effect. Otherwise, you wouldn't really know how it worked in practice. And in fact, the belief was that psychotherapy would undo the benefits of medication. That was the scene. Over 40 years ago, they began writing scripts independently, but they were friends. This was not a competition because there were no winners. And for what later became CBT and IPT. So where did I come in on this? Well, John Rush and I were their research assistants, and we were hired to do the kind of work that's left over that research assistants do. I had just finished school, and I knew not very much. That was good. I had no prejudices. Well, let me just give you a quick review of where we've come. As I said, in the 1960s, there weren't any clinical trials, and the manuals were being written, and the clinical trials were being discussed. By 1979, there were 17 clinical trials of various psychotherapies. Most of them were CBT and IPT, but there were other psychotherapies. By 1982, the National Institutes of Mental Health sponsored a multi-center study to test the efficacy of IPT and CBT and medication for acute depression. There was enough data and enough questions to say which should you use when and which is best. At that time, I also felt that because we had a manual, that IPT might be used in primary care. So I started to modify it and make it simpler, shorter, and easier to understand. In fact, the scripts were a lot easier than we had in the original manual. And I think the modification scripts were probably better. Now, it wasn't until 1984 that the first IPT manual was published. The reason for that is that Jerry was he was a scientist, and he did not feel that we should publish a manual until the psychotherapy met the standards of medication. And the FDA standards were 2 clinical trials outside of the people who invented the medication that showed it worked. By 1984, there were at least 2 clinical trials showing that IPT worked. Mostly they were done in Pittsburgh, but there was another group, I believe in Puerto Rico, that was also testing it. So against that background, we published the first manual. Well, a lot happened in between. And most exciting thing was in 2003, and I'll tell you about this one later, did the first trial in sub-Sahara Uganda. By 2017, there's 130 trials of IPT. There's actually more by now. And there's 300 trials of all psychotherapies for adult depression. And there's probably more of that. There's a lot more of CBT than IPT. 2019 is a burgeoning of international training and research. It's the hottest thing in therapeutics in places like Africa. And in November 2021, we had the meeting remotely of ISIPT, that's the international organization, and 28 countries were represented there. So we've come a long way. I'm going to give you a brief tutorial on what IPT is. For those of you who don't know it and may be interested in learning more. The basic assumption is whatever causes depression, and certainly there's a strong genetic background to that, there's a relationship between the disruption of close attachments to the death of a loved one, disagreements, life changes, loneliness, isolation, and the onset and recurrence of symptoms such as distress or depression. And what we have found that these triggers are conserved across cultures, as we've done many of these international studies. This is another simple way of putting it. There's a genetic background. We don't really know what that is. We know environment has a great deal of effect, especially childhood adversity. But there are current triggers, and what the psychotherapy does, at least the IPT therapy, is deal with the current here and now triggers of depression. And they've been defined in 4 problem areas. And the phenotype they deal with are distress, depression, or anxiety. Now, there's been many more adaptations. Some work very well, like PTSD works very, very well. Some of them don't work very well, like substance abuse does not work very well. I think there's 2 negative clinical trials well done showing that IPT really didn't do much for people who are opiate addicted. So that's good, because anything that works for nothing is probably nothing. Nothing works for everything. This is just and I'll go into each parts of these briefly. There's the initial phase, the middle phase, and then the termination phase. And the important thing is that the time period for the IPT is specified and agreed upon at the beginning. That doesn't mean that a person can't go on afterwards, but there's a time where certain things must have happened and you need to evaluate it to see whether that's the right treatment, whether treatment needs to be changed, something added, or maybe treatment ended. Interestingly, that time period has varied greatly. When we go into Mozambique, it's 4 sessions. When we've done some things in New York, it's 3 years. So time period is flexible. The initial phase is the introduction, identifying the symptoms and the treatment history. Let me tell you that when we started writing the manual, this was heresy. The conventional belief at Yale University, which is a very fine university, very psychoanalytically oriented at that time, not now, was that you didn't identify the symptoms, you didn't get a history. You let the patient express through the transference who they were, and the therapist stood back. Fortunately, I was asked to write the manual, and as I said, I was completely ignorant, and I didn't know that that was the right thing to do. So I sat down and talked to people who were running drug studies and came up with this. And of course, Jerry was heavily involved, and he was had a major part in modifying everything I wrote, but he also had been trained in medication clinical trials. So you get the history, you explain the symptoms, the distress, and the relationship to the current problem. You give the patient the sick role, which means you should take care of yourself. You have an illness, but it's not who you are. It's illness with a certain course and you're getting treatment and you'll get better. But it's okay to relax and not put so much trouble on yourself. The interpersonal inventory is not a childhood history, although one wouldn't stop if a patient wanted to talk about it, but it's what is going on in the patient's life when they started to get symptomatic. And that's how we get the problem area. Was it a grief, an unresolved death? Was it a dispute with a significant other? Was it a change in life, transitions, or is it just loneliness and isolation, recent or chronic? And then, of course, the time limit is discussed. The problem areas are the middle phase, and they're in the manual, the script for how you might work out these problem areas. And as I've said, there's grief, disputes, transitions, and deficits. What is really amazing is that this works in Mozambique and Uganda. I mean, we train community health workers, and this is the language they get. And it works. There's a certain human universality of these kinds of problems. Now, how you handle them may be different. For example, in Uganda, if a woman is having a dispute with her spouse and she's very angry about it, she may be helped to identify what she's mad about, but she isn't encouraged to go and tell him how she feels. The two ways we learned culturally acceptable is that she asks her brother or her father to talk to her husband, and she cooks bad food, which gets the message across. So these are cultural nuances, but they're not any different in that a dispute with a significant other is a very distressing thing, and helping to resolve that dispute, whether it's renegotiation or starting up the conversation that was at an impasse or dissolving the relationship, seems to have a certain universal flavor. And in the middle session, you work on these problems, and it's spelled out in the manual. And of course, problems can change. One problem that's examined may evolve into something else when the person feels comfortable with you. One of the more interesting ones we had was out of Egypt. We were asked to modify the manual for Muslim countries. So we asked them to send us cases. And one of the cases I'd never worked on before was what happens when the second wife arrives. And because there were multiple marriages where this was being practiced. And that was not very difficult. It was very similar to a dispute that needed to be uncovered. And in fact, in that particular case, the dispute was not about the other woman arriving. The dispute was that there wouldn't be enough money to take care of the first wife's brother who was ill. So it was a very interesting learning experience. And termination there's nothing special about it. You deal with feelings about ending, review the progress for identifying and dealing with recurrences, find out whether the treatment really worked and what more needs to be done. And it varies greatly. In New York City, it always needs more treatment. In Mozambique, it rarely needs more treatment. So we don't know whether that's to do with custom or the severity of the problem. Certainly in Mozambique, no one's ever had psychotherapy. And oftentimes things work out very quickly when the problem is uncovered verbally. In New York, at least in the clinic we're working on, people are used to long-term psychotherapy. So it's ending it is a little bit more tricky. Now, I am not going to go into the efficacy data, but I assure you there's efficacy data. We are not selling patent medicine. We're not selling a religion. If it doesn't work, you shouldn't use it. And Pim Cooper has done a number of meta-analysis on many, many different studies. And this actually isn't his most recent one. and he showed that IPT was effective in the acute treatment of depression. He's done others looking at it in adolescents, and he's redoing another one for us as we put together some new data. This is just from his study to show on the right-hand side is where it works and the left-hand side where it doesn't. So, and there've been other studies like this. And as I said, this is depression, where our own work shows that it does not work for substance abuse. I also want to say it doesn't work for everybody. And there are many times when I supervise residents at the end of maybe a 12-week session, I say, you know, I think they need another kind of psychotherapy, especially somebody who doesn't like to deal with interpersonal problems, but may just like to deal with thinking. And then we would refer them to CBT. And we're always open to encourage medication. In Mozambique, medication is not available. In New York City, medication is widely available. And we certainly don't discourage that if a person is not sleeping and eating. Now, this was the first manual in 1984. You can see my late husband, who died in 1992, very young, was the first author of this. Okay, so where are we now? That kind of the background. And now I'll tell you some of the fun part. Well, I told you about interpersonal counseling, which we developed. It was simpler, more scripts, briefer in duration. And first was a 1987 paper, and then we revised it in 2014. The reason I bring this up is that a lot of the work we're doing internationally, globally, is using the IPC manual, mainly because they think the scripts are much simpler to read. The concepts, the problem areas, the sick role, the interpersonal inventory, those are the elements of IPT. It's all there, but the scripts are simpler. Well, these are some of the expansions, and I'm not going to go into all of them. I just want to be able to brag about them because we are proud of the fact that there's been such expansion. It's particularly good, I think, in pregnancy and postpartum. In fact, the U.S. Preventive Task Force has recommended IPT and CBT to be used as the first treatment for depression in pregnant women, as more data has come out on the potential effects of the SSRI on developing fetus. And there's all the work done by Laura Mufson and Jamie Young on adolescent depression. Very good work on eating disorder. Eating disorders, well, it doesn't work for anorexia, but nothing really of the psychotherapies have been shown to work for anorexia. When compared to CBT, it took longer than CBT to work, but the effects were enduring. And PTSD, I'll show you at the end because there's a new book that's come out by John Markowitz. And telephone IPT, we were very inventive many, many years ago, but of course now with the pandemic, it's all telephone. Let me go into our global reach. This is out of date. And this is where we've done training or there are efficacy studies. There is somebody who has translated the manual in Russia, and we haven't been able to locate that person, I guess, right now. But Dr. Morozov, if you know who they are, please let me know. Before all of these tragedies began, we were on a lookout trying to contact people, and we have stopped that now. But somebody has translated the manual, and we would love to find out who that person is and get them to write about it for us. So please contact me if you know who it is. And every day we get something new. Now, these are not clinical trials. They're what we call humanitarian or clinical efforts. This is the latest manual that was published in 2018. And I think this is, if you're looking for a manual, this is the one to use. And I just wanted to show you that it's been translated into Chinese. The Chinese are very interested and have a whole program of IPT. The next slide, I think it's more Okay, this is the WHO. The WHO was very interested in our group IPT, which we had used in Uganda. And they took it over and they published this beautiful book, and they endorsed it, and they give this away free. If you want to have a paper copy, you have to pay for it through them. But we turned it over to them, and it's available. And it's been translated into Chinese, Swahili, and recently Portuguese. So I don't know what else it's been translated, but those are the ones I've heard about. Okay, I'm going to tell you about the first clinical trial then of psychotherapy in Africa, as far as we know. One day I got a call saying that somebody wanted to have IPT in Uganda because they could not deal with the serious depressions. The local healers could not deal with it. There had been civil wars, there had been fighting, there had been many deaths, many women left alone, and they needed to do something, some treatment. And they thought IPT would be good because in Uganda, people live in families and in groups, and that it would make sense. So Paul Bolton and Judy Bass from Hopkins were going to be the scientists developing the study, and Leonard Verdelli, Kathleen Clougherty, and I were the people who were going to modify the manual. Well, that was a task because we didn't know anything about Uganda. And we said, sure, this is a challenge. This was the rationale for why they were interested. It was because depression was a major source of disability. The things I've said, medication wasn't feasible. And they wanted us to manualize. Well, we frankly couldn't have sat down and manualized something we didn't know anything about. Instead, we took the manual that we had and we simplified it. We took the one that I had mentioned, the IPC one, the simpler language, and we made it simpler to understand, and I think better. And then Leonard Verdelli and Kathleen Clougherty went to Uganda for almost a month, and they were going to train people, and we felt in the course of training people, we would see what needed to be adapted. So they did that. They came back and a clinical trial was done, 284 people. And we were not doing the clinical trial. In fact, to be honest, to keep ourselves clean, we just did the manual and did all of the training of the health workers. But we did not analyze the data. We helped write it up, of course. And as you can see, at the end of the treatment, which was about 16 weeks, and then at the 6-month follow-up, there was a very strong effect for IPT. And a second study was then done in the northern Uganda with adolescents. But this was legitimate. None of us were really involved in the analysis, and we were really pleased about this. Well, not everyone really believed it. And about 6 months later, there was an article in the New York Times about group therapy helps ease the burden of AIDS in Uganda. And AIDS was a big motivation also for why they wanted to treat depression. And I said, well, that's really interesting. Somebody else is working in Uganda. So I delved into this to find out more. And as it turned out, the New York Times had sent investigative reporters out to interview the people we trained and the patients, because they thought they were going to find a big story there, that it really didn't work. And we didn't know anything about that. And this was the result, that it really did work, and that patients did report that they were helped. And see, it was easier to help the patients in Uganda because they hadn't had 5 years of psychotherapy. It was the first time that they were put in a group to talk about the burdens that they were facing because of the Civil War, because of the deaths, because of the poverty. And it really helped a great deal. With the other surprise, we were committed that the control group, who only got standard therapy, which meant nothing, they were seen in primary care, but we were committed that if our treatment worked, we would then treat the other people, that the ethical thing to do. Well, we were sideswiped by that one. Sean Mayberry, the former diplomat in this area, and wanted to do something for his people. He was no longer working as a diplomat. And he organized the people we had trained in IPT in Uganda, in Kampala, and he started running groups. And he got all the people that we hadn't treated, plus more. Now, since 2014, he's treated over 40,000. I didn't update this slide because I liked the picture. And he's treated hundreds of thousands. And he's also moved into Zambia. And during the pandemic, he moved into telephone, because everyone has a cell phone in Uganda. They may not have indoor plumbing, but they have cell phones. So it was very easy to do. And he's developed a nonprofit organization. And I think he wants to bring this to the United States. But he's been doing this as a nonprofit since 2014, and we've been in touch with them quite a bit. So there's a lot of psychotherapy going on in Uganda and now in Zambia. Not just a list of some of the things taken at random of what their humanitarian efforts. They're not ours, but there's what people have been doing. Lena Verdelli has been responsible for a lot of this, and also Paul Ravitz in Canada. But there's many others. And it's been used after earthquakes, violence in Kenya, Bogota. The Syrian refugees is what Len is working in now. And I can't imagine the load that's going to be given this current disaster that we all know about. Okay, let me tell you about Mozambique. Mozambique is going on in my division at Columbia. I run the Division of Translational Epidemiology, Implementation Science. And Milton Weinberg is a psychiatrist from Venezuela who's been working with populations all over the world. And he has set up and funded by the NIH a big implementation study in Mozambique. Okay, it's called PRIDE. I forgot what that stands for. But the hub is in sub-Saharan Africa, in Mozambique, but it's also going to expand to other parts of the world. And I think I have next slide that shows the control groups. Let's see. Let's do the next. Okay. His idea was you can't just screen for depression, but to offer a comprehensive program in primary care. And it is very elaborate. And patients who come into primary care, which is where patients come, what it's called in Mozambique, they get screened. And if they have substance abuse disorder, there's a brief screen and there's a program for that. If they have depression or anxiety, they get IPC. And if they have suicidal risk, they get safety planning. Now, this is all done with community health workers, and Jennifer Mose has been out there and trained a couple of hundred community health workers. And these are people who are from the community, perhaps no formal education, but are good with people and can be trained to do IPT. She's also developing a digital training program to make it easier to train. And she also uses the computer to help the community health workers stay on track. The treatment is very brief. And at the end of, I think it's 4 to 6 sessions, if the person is still symptomatic, they go into group. But so far they haven't had too many in group because these are people who have never dealt with emotional problems in this way. So at least in the short run, it's been therapeutic. Now, pandemic came, And of course, everything stopped. We can't go to Mozambique or vice versa, although they still have weekly phone calls on Zoom. And the mental health or the health group in the government has taken over some of these procedures, and they're just doing them in their primary care clinics. So we're waiting to go back to Mozambique to finish the study, which is really only the training's done and some of the preliminary treatment. And we'll have some idea as to how this works. Without a clinical trial, it seems to be working, but we don't have the actual data. Now, there's a lot of talk among the psychotherapy mafia about what are the essential elements, and if we all had the same elements, that we wouldn't need any particular psychotherapy, we could just do elements. So it's made us think about, what do we mean by elements? What are the elements of psychotherapy? And I looked up a definition of elements. These are what I consider the elements. The medical model: you're a person with an illness, distress, or symptoms. It's not your fault. You're not a depressed person, you're a person with depression. The sick role, which is take care of yourself, who can help you, and you're trying to solve a problem that brought on the symptoms. We're not changing your character, we're not changing your personality. We're just trying to stop the symptoms, and that's related to the current problem in your life. The interpersonal inventory: who is in your life, the good and the bad, and both are very important. Who can help you and who causes you problems and you're involved in disputes. The problem areas, which seem to work pretty well. We haven't found another problem area. If anyone has one to nominate, please let us know. We target symptom reduction and improve social functioning, not personality. If you're an obnoxious person when you start, you're the same obnoxious person when you end. But we hope that you have less symptoms and you're not fighting so much with people. The time limits are specified, and the focus is on the here and now. So whenever there's arguments about what are the elements, these are the elements of IPT. I said that there's been more reviews of the efficacy data, and this is really a monumental review. Paula Ravitz took all these years when IPT started up until 2017, and she's got a scoping review and historical perspective. It's more than you'll ever want to know about IPT. So different than Pim Cooper, which is a meta-analysis of clinical trials. This includes clinical trials that may have small samples, but interesting outcomes. So first, someone who wants to learn about IPT is a pretty good review to look at. Let me finish with the COVID pandemic. IPT is problem oriented, and you couldn't find a better problem than COVID. And John Markowitz actually was writing a book on PTSD when the pandemic happened. And he talks about the losses and the life events that occur because of COVID: routine, the loss of income, employment, social supports, loved ones. And of course, IPT links events to moods and symptoms, and there's a lot of events there. And the idea is to rebuild social skills. It's not rocket science, but you can see how it fits in well. And I don't think next slide, I don't think I brought the clinical trial. Oh, the reason he also did that is because most PTSD treatments are exposure-based. In other words, in order to get over the PTSD, you have to be exposed to the event. And that's a treatment that works. However, there's a high dropout rate and there's a high refusal rate because people don't want to be exposed to what had caused them trauma. or at least even a mock-up of that. And IPT is affect-focused, non-exposure. It's an alternative, and it focuses on the interpersonal consequences of trauma and the need for being attuned to the numbness that's often caused by dealing with the trauma. And it links the mood to the daily life events, but doesn't necessarily relive the trauma. And he did a clinical trial, and in the interest of time, I'm not sure, I think I took it out. I did, but he did do a legitimate clinical trial that is published, and it showed that it worked as well as a trauma-based therapy. So it's an alternative to PTSD treatments, which are based on exposure and which have been shown to be very effective. Now, I want to end this with the international organization. We have no paid staff. It is totally voluntary. I wish somebody would give us a large donation so we could get at least a part-time secretary. But we have people from at least 28 countries, and we're online, and people work very hard. It's nonprofit, it's global, and it's dedicated to promoting and disseminating training and research and an IPT. It has networks. So any of you who are going to introduce IPT to your program, I would urge you to at least it's not a large fee, to join the ISIPT, because you'll get access to whatever slides and training material that people are doing. It's given away freely. There's mentorship and training opportunities, discount fees if you want to go to the workshops. I'm selling this, I hope you understand. And they have now started a certification program for trainer and supervisors who will be listed. We got a lot of pushback from people who wanted certification because they said that it wouldn't be accepted in their country if they didn't have a certificate. So we didn't want to be charlatans and just give everybody a certificate. So the group actually set up a training program for trainers, and they're working their way through it. I've never seen a group work so hard for no compensation, and it's very nice that they do it. This is, in the way of advertisement, how to join. It's $50 for students and individuals from low and middle income. Just to conclude, I want to make a point. This is not a religion. There's a wide variety of psychosocial interventions, and they play a major role in the treatment of mental health and substance use conditions. And the trend is moving in this direction. I would urge you to read Tom Insel's new book called Healing. It just came out. Tom Insel was a hardcore biological psychiatrist who was head of the National Institutes of Mental Health. And he left that after serving, I think, 15 years. And this book is called Healing. And he takes a much broader view of what's needed in the real treatment of mental health. Of course, we need to understand the biology and how the brain works. And of course, we need new medications. But that part of healing is the psychosocial interventions and the family interventions and the society interventions that will make a difference. And that's what his book is about. I sent him a note and I said, boy, Tom, you really surprised me, because it was a turnaround from his days at the NIH. And I think that's happening more and more. Psychosocial interventions have been demonstrated to be effective in research settings, but they're often not used routinely in clinical practice, which is too bad. There's no standard system in place to ensure that the psychosocial interventions delivered to patients, consumers, are effective. There are no, I did a survey of training programs, and the training programs, at least in the United States, and that was done a number of years ago, and it's being redone, and I don't think it's changed, is that a lot of time is spent teaching psychotherapy, but with the exception of CBT, it's not necessarily evidence-based psychotherapy. And there's no requirements for that. Therefore, if you want to learn any of these therapies, even CBT, you have to do it outside of training. I think it should be part of social work training, psychology training, and psychiatry training for those who want to do that kind of clinical care. We and others have shown amazingly, and much to my surprise, that community health workers can be very effective in low-income countries. I think they can be effective in high-income countries too, and we're going to try that out. There's some barriers that are insurance barriers for using community health workers in the hospital. So we have to try it outside the hospital in the United States. And I think the next slide's the last slide. Those of you who did not know my late husband, Jerry Clairman. He died in 1992 at a fairly young age. And he would have been so shocked at how psychotherapy has been disseminated, how it's used, and that even people remember IPT. So I thank you very much for listening, and I'm happy to take questions.
Thank you, Professor Weissman. That was a very comprehensive talk on one of the major methods of psychiatric treatment in the field of psychotherapy. There is one comment by Daria. Daria, can you make it yourself?
Yes, thank you very much, dear Prof. Kostas. Dear Prof. Myrna Weissman, it's an honor to hear from you directly this lecture. We know your approach very well. Actually, we have a group in St. Petersburg Research Institute of Psychiatry and Neurology who translated IPT in Russian already a long time ago. And actually, we all quoted Clairman Weissman in our PhD thesis, and St. Petersburg Institute works as a WHO collaborative center.
Are you the Russian I've been trying to find?
Yes, we will contact St. Petersburg Institute and will ask who particularly did this translation. Yes, but we have this information in our textbooks on psychotherapy, and our PhD students and our postgraduates have questions at the exams about IPT approach of Clairman Weissman, actually.
Well, let me ask you a question. We're writing a book from Oxford Press called IPT, The Global Reach. And what I'm trying to do is to get people from different countries to talk about their experience, the good and the bad, and what they've done. And that's why I was trying to find this person from Russia. So if one of you are interested in producing a 5 to 7 page, and I can send the details on the use of IPT in Russia, contact me, please, and I can talk to you about it.
Thank you very much. And I'm sure, and Professor Peter Morozov will confirm that we will find people from St. Petersburg Institute, Psychoneurological Institute, and they will share their experience
Thank you. I'm
as
sorry.
they apply over years. And we will be happy ourselves to join and contribute.
Peter, you
Also,
have a raised hand, or it is accidentally? You should turn on your
Yes.
Daria, you had a question? Somebody had a question.
Well, yes, I have a question. Well, first of all, thank you very much to remind us about Jerry Clairman, whom I know since also very, very long time ago. And we met a number of times. It was a wonderful person, really. great researcher. I appreciate very much that you remind us, and especially to the young generation, about him, about his contribution. This was a real personality. So my question is related to transcultural aspects of IPT, because, you know, Russia and US are a country with many of nationality, and we always met this problem after this globalization, migration, and refugee movement, and so on, a mixture, that we should adapt our approaches to treatment, especially in the field of depression, to some particular well, shall I say, nation, ethnicity, because some of them react differently to even to the question. They didn't understand some details, some differences. And your approach is very precise and very scrupulous. So my question is that you have a large experience how to adopt IPT approach to different national groups. Like you mentioned it in Uganda, for instance, it's a different word. I was in Kenya, I worked about 1 month, so that I could imagine. Well, this is my question. Thank you.
Well, we were as ignorant as everybody on how this would work. And there were two things. We did use community health workers who we trained, so that they were able to, it was acceptable what they learned, and they were able to communicate it to the people they were helping. And what we learned from them is that it worked. They understood that if you're fighting with your husband or your children, it's very distressing. That if someone you love dies, it's very distressing for a long time. That if you lose your home, it's very distressing. So the problem areas seem to be universal, and the niceties of it, like you don't scream at your husband, but you just tell your father to talk to him, were trivial. Now that's Uganda, and that's why we are interested in this book, in which we get people from different countries to honestly tell us what they had to change and what worked and what didn't work. So we're in the process of learning that, and I can't answer that yet. But of course, people like to be complimentary to the inventor, and we hope that they're going to give us some answers. But you know, despite all the turmoil and trouble that we are having in the world now, there is such a commonality of humanness and human experience that we see, that we hope that helps get us through this.
So thank you again, Myrna. It was both a pleasure and an honor to have you with us.
Thank you.
Okay? And we hope we will start a collaboration on
I would like that.
On training and research. Now I will pass the floor to Professor Smirnova for the introduction, and ask her to introduce our next speaker, Daria.
Thank you, dear Prof. Kostas. Thank you, dear Prof. Myrna, once again for your amazing lecture. And it's a great honor now to introduce our next prominent speaker, Professor Edward Lazer Shorter, an American-born Canadian historian, who is professor and honor chair in the history of medicine at the University of Toronto, and also a representative of the Royal Society of Canada. Professor Edward Shorter has graduated from the Wabash College of Indiana and defended his PhD thesis in Harvard University. Professor Edward Shorter has different areas of interests, such as social history of medicine, obstetrics, gynecology, psychiatry, psychopharmacology, history of the family, history of the sexuality, Professor Edward Shorter has published widely in this field, including histories of obstetrics and gynecology, the book titled Women's Bodies, the Doctor-Patient Relationship, Doctors and Their Patients, Psychosomatic Illness, the book which you can find everywhere, from paralysis to fatigue, and Sexuality Written in the Flesh, A History of Desire. Professor Shorter, also the author of Partnership of Excellence Medicine and University of Toronto and Academic Hospitals, which traces the evolution of Toronto's academic health science network. Since 1991, Professor Shorter primary appointment has been in the Faculty of Medicine of the University of Toronto. And since this period, Professor Shorter emerged as an internationally recognized historian of psychiatry and the author of numerous books on the evolution of our discipline, including the book A History of Psychiatry, Before Prozac, and How Everyone Became Depressed. In 1996, Professor Shorter also cross-appointed as a professor of psychiatry, and one of his recent books is also very famous, The Madness of Fear, A History of Catatonia, co-written with Dr. Max Fink. And the most recent book, which has been just published in 2021 by the Oxford University Press, is The Rise and Fall of the Age of Psychopharmacology, which is of great interest among all of us. Also, it's very interesting, a paper published in Acta Psychiatria Scandinavica in the journal about the doctrine of the two depressions in historical perspectives, which is very interesting, about melancholic versus non-melancholic depression. And today, Professor Edward Shorter will present his lecture, which is titled The Current Rise in Suicide and How to Interpret It. Thank you very much.
I'm very grateful for this invitation today to address this distinguished group, because it gives me an opportunity to talk about a subject that has really become very urgent in American society in particular, to a lesser extent globally, and it's the current rise in suicide. How are we to understand it? Because I think the current interpretations of this rise are largely wrong. In the world as a whole, suicide rates have not been on the rise. And this is a graph that shows no particular upward trend, at least not before the pandemic, in suicide. These are OECD data. By contrast, in the United States, rates are up dramatically. Now, let me just add a couple of codicils. Rates are not down in some places, for example, Russia. And these data cut off before the pandemic, when there was a steeper decline related to that specific cause. But I want to talk about the US, where events have taken a different course. The US is undergoing something of a suicide crisis right now. And this is a headline from Medscape Medical News, a US publication directed at physicians. And it tells us that pediatric organizations declare a national emergency in mental health. This is sort of specifically American. The American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, and blah, 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 have all declared a national emergency. Well, COVID-19, they say, has taken a serious toll. The organizations say, on top of already mounting challenges, policy change are urgently needed, they say, and blah, blah, blah. Today's declaration is an urgent call to policymakers at all levels of government. We must treat this mental health crisis like the emergency it is. But unfortunately, the solutions that they come up with are solutions that are likely to be unproductive. Now, I want to focus on juveniles and young adults in particular, because suicide rates are up for them quite dramatically, as this graph shows. Homicide, another kind of social pathology, is down. Suicide is up. So it's this section of the graph that takes us from 2006 to 2017 that cries out for explanation. Well, here's another way to look at it. Suicide is the only thing that's up. And the green line there shows this dramatic rise in suicide over about the last 30 years, whereas everything else is down. Stroke, heart disease, AIDS, childhood leukemia have all dropped off dramatically. Suicide has risen dramatically. And this is extremely interesting. Now, men commit suicide more often than women because they use more fatal means, and this graph makes that point. Firearm suicide by males is the dotted line way at the top, far exceeds any other technique of suicides, and efforts to commit suicide with a firearm are generally successful. Whereas for women, poisoning by females is much less successful and is much less frequent. But it is women and girls who are of interest here because their rates have risen more rapidly. Okay? Let me see if I can drag this down a bit. Suicide rates have risen sharply among girls and adolescents. Here are emergency departments admissions for suicide attempts and ideation for children 5 to 18. And the gray line is the crucial one to follow. It's pediatric attempts and instances of ideation for patients in that age group. And look how dramatically they've gone up in about the last decade. It's really very striking. And it's true that women have far more suicidal ideation than men do. They commit suicide less frequently, they use less effective means. But if we're talking about whether you are seriously considering attempting suicide or not, the top graph, the 2 bars from the left, make this point. Males who are percentage of high school students who seriously considered attempting suicide or thought about it in the last year, the female rate is double the male rate. So this is the rate of girls in high school who thought about suicide twice as often as boys. So this is something that just cries out for an explanation. This is the puzzle. Why all this suicidal ideation why does it exist, and why has it been rising? So what is going on? Okay, one in the kind of official interpretation that comes from American psychiatrists who control JAMA psychiatry is deaths of despair. Okay, and this is the title page of one of those articles. Is the rising suicide a result of rising deaths of despair? Well, no, I don't think so. It really stretches things to assume that despair is rising in this prosperous country where unemployment is at an all-time low, and women who would be the proposed victims of this despair have never been more successful in their careers. And yes, I know you can always find something to despair about, but on the whole, the despair burden should be decreasing rather than increasing. So this definitely is not the explanation. So let's go back to the drawing board. Forms of suicide. Now, only one of these forms is psychiatric in nature, and that is the psychogenic form, meaning melancholia or serious depression. I think it's a mistake to talk about depression as though it were a single phenomenon. There are different kinds of depressions. And melancholic depression is the serious kind, and it's often accompanied by suicide. This is why it's such a serious illness and cries out so urgently for treatment. But melancholia is not the entire story, even though it's an important part of the story, and we're going to come back to this. There's sociogenic forms of suicide, and that means suggestion coming from social media, and of course, this is where girls and young women come in. They are subject to sociogenic forms of suicide. And then finally, there's classic Durkheimian suicide associated with Anomi. And I'm going to come back to that as well with a more careful explanation of what that entails. Okay, psychogenic suicide means basically melancholia. This is a very real illness, and it's not at all the same as neurasthenic depression, a very different kind of depression. And since time out of mind, suicide has been associated with severe depression or melancholic depression. It's the oldest disease in psychiatry, and it's still very much with us today, even though the DSM, the Diagnostic and Statistical Manual of the American Psychiatric Association, doesn't recognize it, and they've completely muddied the water by introducing this unfortunate concept of major depression. And this is, I highlighted this comment by Australian psychiatrist Gordon Parker. Not only has major depression become the biggest game in town, it's become the only game. And this is a major scientific blunder. If you think, doctor, that your patient has major depression, you will have no concept of whether they are at risk of suicide or not. So this is the clinical bottom line. If you can't determine what kind of depression they have, you won't be able to assess them for suicidality. So there is a solid core, as I've mentioned, of serious depression in those who commit suicide. Max Fink and Michael Taylor say 60% of those who commit suicide do so in the year after a depressive episode. So this is a major cause that we're talking about here. Depression, especially melancholic depression, can never be left out of the suicide picture. But that is not necessarily the key factor in the young. Okay? That's the crucial difference. Historically, a majority of suicides were melancholic in nature, as this Greek statue suggests. An individual with melancholia. He has the slump and the faces of the melancholic individual. But now, changes in the offing owing to the influence of suggestion. Suggestion. This is the phenomenon to be explained. There have been huge increases in suicide among US girls and young women 1999 to 2017. Older women, whose columns we see on the right, have the highest rates of suicide. Younger women have the greatest increases. The age group 10 to 14, suicide almost triples. The age group 15 to 25, suicide rates almost double. Those are increases that are much greater than increases in other age groups, even though the absolute rate in other age groups is higher. And this has happened in a period of 18 years. So this is really history in the making that we're talking about here. Well, how about boys and young men? The increases have been much less dramatic. For the boys are in the blue bar, only a small increase from 1999 to 2017 for the age group 10 to 14. Ditto for the age group 15 to 24, the blue bar. But look at the chart on the right. Look at this giant red tower, which marks the increase of suicides in females 10 to 14. Vastly outranks the increase in boys. And very few people have asked this question: why is it that young girls are so much at risk of suicide? And they haven't really asked the question because they don't have a good answer. So this increase in suicide is very much female driven, and it's very much female adolescent driven. So we're looking at sociogenic suicide. Suicide as a result of suggestion, not of melancholia. People have always been suggestible. This is not something our society has invented. But suggestion spreads most rapidly in an atmosphere of hypercommunicability. Hypercommunicability, that means social media. Yet in the past, suicide by suggestion did occur. Exhibition number 1 is Johann Goethe's novel, The Sorrows of Young Werther, The Sorrows of Young Werther, Die Leiden des jungen Werthers, 1774. Disappointed in love, Werther commits suicide. And here he is now, he's just shot himself, and all the relatives are grief-stricken and so forth. It's a very dramatic story, Goethe's novella. This touched off a wave of romantic suicides across Europe. These were clearly all suicides by suggestion. They were suggested into it by the reading of a novel of this young author. But in general, suicide among the young was uncommon in the distant past. There's a whole tissue of rites and rituals that held young people together in traditional society. Here we're looking at the reenactment in France of a courtship rite. So this is a huge expression of community solidarity. And these people simply did not commit suicide. Today, by contrast, rites and rituals have vanished among the young. Suicides have soared. Here, a mother grieves. So the single most important factor in the suicide increase, especially among girls and young women, is social media use. Here we're looking at a time bomb of contagion. Social media use correlates with suicidality. The findings, says one author here, findings of this review suggest that there's a positive association between various patterns of digital use, i.e. frequency of social media use, smartphone addiction, suicide-related social media use, sexting, and suicidal thoughts and behaviors in adolescents and young adults. So this is a very powerful statement that suicide is right in the middle of this behavioral constellation. Another authority on the correlation of social media with suicide. The results add to the increasing body of research indicating social media use is clinically relevant, a clinical relevant parameter, as well as further supporting the incorporation of a social media assessment within taking a psychiatric history. So this author urges that this be clinically implemented. Social media use as a way of figuring out whether your patient is potentially suicidal or not. An interesting suggestion. So in the background is the fact that the whole mood picture in children and adolescents has changed and is changing. Things like childhood depression, adolescent depression, were never really on the radar before 1970. And it was virtually unheard of for children to take the few antidepressants that existed in those years, like the tricyclic antidepressants. These are drugs for adults who had mood problems. Look at this headline from the New York Times. Use of antidepressant medicine for young patients has soared. And then they give us the stats on, this is really just a fragment of time here that we're looking at, but it's an important fragment. And you can add many such fragments to this one. Prozac, ages 13 to 18, is up from 1995 to 96, up 47%. Paxil, up 113%. That's just from one year to the next, in the middle of the 1990s. These increases have continued. It's become really very common now for children and young people to take psychoactive medications, very often a combination of an SSRI plus a second generation antipsychotic. So what has changed in the life of young people? This is an image from France. One girl is kissing another. One of them has blue hair, the other doesn't. You would not have seen this in France 10 years ago. And social media has become omnipresent. That is the big change. Here, the cartoonist invites drivers to slow down their distracted children, and all the children are looking at their iPhones as they cross the street, quite oblivious of traffic. This is a cartoon that exaggerates the reality only slightly. And social media means contagion. Ideas and feelings are communicated with the speed of light in social media. Here's a headline from the UK. 1 in 4 teenage girls are depressed by their own accounts. 1 in 4 teenage girls believe they're suffering from depression, according to a major study by blah, blah. The research, which tracked more than 10,000 teenagers, found widespread emotional problems among today's youth, with misery, loneliness, and self-hate rife. Charity said girls were facing a huge range of pressures fueled by social media, with parents far likely to detect problems in their sons where levels of unhappiness were lower. So the epicenter of unhappiness in this population is the females, not the males. In total, 24% of 14-year-old girls reported high levels of depressive symptoms, 1 in 4. This means that if you teach a classroom with 40 students in it, 10 of them are going to have depression. This is a lot. Hugely influential in adolescent suicide has been the story of Sylvia Plath, whose depressive trajectory was recorded in her journals and who suicided in 1963. And in the young female social space, this was a major event. Her death was very widely followed and had a big impact. I think this was the beginning of the tidal wave of female depression that has since engulfed us. It started with the death of Sylvia Plath in 1963. This is the cast of HBO's teen hit Euphoria. I dare say that some of the people who are on the call today are familiar with Euphoria, even if some if some of the older people are not. It is widely followed in the teen universe. And in the lower left-hand side, we see one of the characters who's known as Rue. And Rue is depressed, and she may end up suiciding. Who knows? There's lots of speculation online about how this is going to play out because it's so compellingly interesting. And Cassie on the lower right threatened suicide with a corkscrew. Go figure. Each one of these young women is a contagion magnet, and their misadventures on HBO are followed by tens of millions of young women. This is a very considerable social phenomenon, this single TV series. Adolescent suicide, now this is studied scientifically by looking at clusters of suicides. And there are a number of clusters. They all come up with more or less the same conclusion. This is an example of one. Among those who posted suicide cluster-related content to social media, 25% reported suicidal ideation or suicide attempts during the cluster. Exposure to suicide cluster-related social media content was associated with significantly increased odds of suicidal ideation and suicide attempts during the cluster when compared with students without any suicide cluster-related social media exposure. So this is a direct statistical confirmation of the contagion effect that takes place within these subgroups of adolescent females. Okay. An example of contagion, 13 Reasons Why was a TV series, 2017 to 20. Many of the people on this video this afternoon probably never even heard of 13 Reasons Why. Every adolescent in the United States and Canada has heard of it. And say the authorities who've studied this as a social phenomenon, to our knowledge, this study is the first to examine the associations between suicides and the release of whatever this is blocking out the of reasons why in the United States. The associations identified here do appear to demonstrate an increase in suicides that is consistent with potential contagion by media. That's the crucial phrase. Specifically, excess suicides of approximately 15% occurred in the first month after the show's release in 2017. In the main target group, 10 to 15-year-old individuals. Significant associations were present for all of the 3 months in which the show was discussed on social media, and it was widely discussed. Our findings appear to point to the need of engagement by public health and suicide experts to engage with members of the entertainment industry to prevent further harmful suicidal portrayals. Well, good luck with that, eh? There's much more research that could be cited, but I won't cite it. There is virtual unanimity that involvement with social media increases suicidal ideation and attempts among adolescents, females in particular. And the mechanism seems to be contagion. Simply coming into contact with an idea increases the risk that you will dwell on it. And if the idea is one's self-destruction, the consequences can be tragic. And then let's talk briefly now about the third kind of suicide, which is the kind that most people who've studied sociology are familiar with. Classic Durkheimian suicide from Anomi. And Anomi is a word to conjure with in sociology. So here's a presumably anomic young woman looking at herself in the mirror. Durkheimian suicide involves the disintegration of previous norms. And in normlessness, people become disoriented. Here's Durkheim himself. That was Durkheim's idea. And it has influenced writing on the sociology of suicide for 100 years. Anomi, Durkheim, The Suicide, 1897. People find the increased freedom of choice in modern society disorienting. They become detached from their former roots in community, confront society alone. Thus disoriented, they are more likely to commit suicide. So this is a familiar kind of Gemeinschaft to Gesellschaft argument originated by Ferdinand Tönnies in 1887. And Durkheim quarreled with Tönnies about specific mechanisms, but on the whole, the significance of the passage from small organic communities to big anonymous cities has held up. Suicide, as I've already observed, was almost unknown in the traditional peasant world. So here's the thing. If you are active on social media, you are not going to be anomic. Durkheim could not have possibly anticipated social media, but it creates the opposite of rootless unconnectedness. Teenagers who are badly texting one another are anything but unconnected. Yet suicide among these young girls has soared. If we extend the period to 2021, the results are even worse. The Centers for Disease Control and Prevention found that between March and October 2020, emergency department visits for mental health emergencies rose by 24%, rose by a quarter for children ages 5 to 11 years, and 31% for children ages 12 to 17 years. These are huge increases over the period of a year. Emergency department visits for suspected suicide attempts increased nearly 51% among girls ages 12 to 17 in early 2021 compared to the same period in 2019. These are enormous figures, and they've gone largely unreported and unanalyzed because people don't know what to make about this. They have no idea what's going on. Well, so why all this suicide? What kind of a take might we be thinking about? Well, the standard media take on this, shared by some academics, is that many people are very lonely and that this leads to a rise in such social pathologies as suicide. And just by way of example, I'm showing you this recent story in the Atlantic, and it's about loneliness. I think very few readers of the Atlantic are lonely, but journalists imagine that they are. And so we learned that Dr. Vivek Murthy and Arthur Brooks discuss loneliness, what it feels like, how difficult it is to identify the remedies to alleviate its impact on our daily lives. This would suggest to readers of The Atlantic, which is an American intellectual publication, that this really is a very urgent kind of social problem, alleviating loneliness. And is that right? And maybe this is an urban myth, or at least a half myth. There's lots of emotional support out there. Now, this is a very interesting survey. Perceived social and emotional support among adults, United States, in the second half of 2020. So they went out, the NCHS data gathering is very careful, very precise. And so they found that more than 3/4 of adults aged 18 and over always or usually received the social and emotional support they needed. In other words, are they lonely? The answer is no. No, they've got all the support they need. Why would they feel lonely? And even in one-person households, lots. Look at the top green bars. Do you feel lonely? Married, 81.5% say no. We have all the emotional support we need. Living with partners, same deal. Living alone, a little bit more loneliness, but not a lot more. 71.6% not lonely, not lonely, receiving the emotional support that they need is 3/4 of the population. Household composition, one adult, no children. Hey, these would be the classic loners, right? No, 67.6% receive all the emotional support that they need. So these are very impressive figures as a refutation of the loneliness, anomy, social disintegration hypotheses. People who are anomic and whose worlds are disintegrating were somehow missed by these interviewers, put it that way. So Durkheim's legacy is a myth. The legacy of 100 years of Durkheimian sociology may be the false belief that the world is full of desperate, disconnected, lonely people who are inclined to commit suicide. The most suicidal part of the population in terms of increasing rates turns out to be girls and young women who are anything but loners, many of whom still live with their families and who have suicidal ideation, not because of anomy, but because all of their friends in social media are discussing it. In other words, young female suicide today is anything but anomic suicide. These female teens and young women are totally latticed into networks of suggestion. Now, there's another term for illnesses spread by suggestion, and that is mass psychogenic illness. Let's take an example far removed from the world of suicide, the epidemic of Tourette syndrome among teenagers, especially girls. And I'm quoting now here from an article on epidemic Tourette's. Katie Krautwurst was a high school cheerleader in Leroy, New York, when the twitching began. In October 2011, she woke up from a nap and started to spasm. A few weeks later, her friend, Farah Sanchez, also a cheerleader, you get the idea that maybe a network here, also a cheerleader, began to experience the same symptoms. More and more girls followed, shaking, stammering, fainting, unable to control their arms as they flailed around their bodies. Eventually, at least 18 people in Leroy, including one boy and a 36-year-old woman, were affected. Okay, this is a bubble of contagion, in other words. So teenage suicide is another example of mass psychogenic illness. Well, it's a research hypothesis. What's to be done? What action agenda arises from this analysis? Point one, addressing today's youth through the main media or lecturing to them is hopeless. The message does not penetrate the social media bubble. If today's suicide increases as a result of contagion, what is required is counter-contagion. And that means hearing anti-suicide messages from influencers who are their peers. Now, this term influencers is something that all of you may not be familiar with. It's young people, of the same age on social media whose posts, whose social media involvement of various kinds attracts a lot of attention, attracts a big following. They're known as influencers, okay? So this is a typical influencer as seen on TikTok. Again, older people who are monitoring this lecture may not know exactly what TikTok is any more than you would know about 13 reasons why, but this is huge. And these influencers are very influential. So what is needed is a network of people like this to sell anti-suicide and not to sell jewelry. Well, how to recruit such a network and pay for it? Well, this is what NIMH exists for. The suicide of young people is a major problem in public mental health. The billions of dollars that NIMH pays for curing the mental health of the population are largely thrown out the window. It's spent on useless projects. Something like this would creating a network of counter influencers is something that would never appeal to, never occur to any of the bureaucrats at NIMH to finance. And so we need a change, of course. Thank you.
Thank you very much. Thank you very much for your impressive lecture, dear Professor.
Thank you, Daria.
So do you think that the only anti-contagion can help us against this contagion, the bomb of contagion?
Well, nothing else seems to work. These kids are not really susceptible to anti-suicide messages from the big world. Oh, above all, don't commit suicide. That would be awful. This just goes off them like water off a duck's back. It has no influence. So how do you reach out to them and influence them? How do you get through to them? Well, I'm suggesting that the use of counter influencers might work. Nobody's tried this. It's never been attempted. But it would make sense for NIMH or some other big budget organization to say, okay, we're going to do a pilot study. We're going to try setting up a network of counter influencers and plug into some kind of network where suicide is actively being discussed, and see if this makes a difference compared to the control population. We'll have as the influencers be the talking heads on CNN. Okay, we'll have them put out anti-suicide messages, and we'll see who has a bigger impact on suicidal ideation. This would cost a sizable amount of money, but it would be an interesting experiment.
Well,
thank you very much.
I don't expect to be efficacious simply because an influencer is an influencer because it bets, it capitalizes on the negative emotionality, which is intriguing. So an influencer who does not capitalize on the dark side will soon be out of audience. So I'm not sure that this will work.
Well, Costas, there are lots of influencers on social media who talk in a positive way about things like sexuality.
But they do not. They do. You know, I don't have more than 12 years in the field of suicidality, of suicidology. I first started working in the field with the rise of suicides in Greece, with the austerity and the economic crisis 12 years ago.
Right.
And Greece was and still is one of the countries with the lowest suicidality in the world. What was the first thing that struck me was that there is a very strict geographical distribution of suicidal rates. There are only a couple of 2 or 3 mental conditions that manifest a difference. One is eating disorders between males and females, and suicidality between countries, among countries. And this is so geographically embedded that nothing else seems to matter. For example, a lot of people talk about religion, but Kazakhstan is Muslim and has similar suicidality to Russia. while Poland has similar to Russia, Italy similar to Greece, Egypt similar to Greece. So it's geographic, which means a number of things, including genes. That's the first comment. The second comment is that,
well, Costas, let me just respond to that, and then you make the second comment, okay? Okay.
yes.
So when you talk about comparing, you talk about an ecological analysis, comparing different regions and so forth, you're talking about different rates, comparing different rates, and lots of
basic rates, baseline rates.
Yeah, but lots of factors go into determining the baseline rate. It's very hard to pin down why Hungary is so different from Norway. But what I'm talking about here are trends. What accounts for this trend, as opposed to the overall rate for teenage girls much lower than for 45-year-old women, but it's their trend that is interesting. Now go ahead and make your second observation.
The second observation is that Hungary, which is a model country for suicidality, model is unfortunately has a negative connotation here.
Yeah,
right. had high suicidal rates during the Austro-Hungarian Empire, during the Soviet era, during the transition to a free market, and currently has also high suicidality rates, which means that this particular geographical area, no matter the economic situation or the political situation, the socio-political situation, has high suicidality rate. And during the Middle War period, it was notorious for the Smiles campaign in order to reduce suicides. You know about that they were
total failure.
yes, but you know that they were putting smiles, drawn smiles on face to. Anyway,
as though suicide was somehow caused by unhappiness, which it is not. Go ahead.
The next thing is that the three theories that you showed, mental illness, the Durkheim's
contagion,
yes, and the Durkheim's theory,
yeah,
seems to today they seem to be even more interplexed, intercorrelated, and affect one another. For example, let's make a suggestion that since you have such a protective environment during the childhood today in most Western countries, most developed countries, you have a very low infant and child mortality. Children who wouldn't have made it during 200 years ago, 2 centuries ago, today they reach adolescence. They could have died out of accident in the countryside or whatever. Today they make it into adolescent, but psychologically they are prone to all kinds of dangers and mortality.
But that would be true of every country in Western society.
It is true for every country. Also, this could be the reason why all mortality rates drop and only suicidality rate increases. Also, we have a fluctuating course through decades. I mean, we had a peak in the 70s. We experienced a peak 30 years ago. We are now experiencing, so there could be a cohort effect of, let's say, 25 to 30 years. It's not clear, but it seems we have every 30 years we have a peak.
Yeah, you say that in one of your publications, and I thought it's a very astute comment that it's very hard to link suicide to some particular traumatic event, and I agree 100% with that. Tell us, in Greece, has there been an increase in suicidality, in suicide among young females and girls?
Let me make my final comment. It's on Dukheim's theory. If you interpret Dukheim's theory in terms of loneliness, then yes, you are right. But anomi means nomos in Greek means the law, and anomi, the way Dukheim conceived it, is that you do not have a structured environment
Yeah, that's right.
Freedom is too much, and freedom is stressful, and many people, for a minority, this is unbearable. So it's not loneliness, but no matter how supportive the environment would be, if they are not held in a very tight way, the way in rural communities was done,
Right.
these people.
Right.
So Dukheim is not a matter of loneliness; it's a matter of freedom. Freedom as a risk factor.
Well, I think Durkheim's idea was that people in the Gesellschaft are lonely because they don't have all these supporting structures that the village community offered. And he doesn't dwell on with the term loneliness, but I think the Anomi does boil down to loneliness among other kinds of social pathology.
So for Greece, we had, I don't remember exactly, it's something like 25% increase, which is huge, but the baseline was extremely low.
Right.
We're talking about 120 deaths per year more. So it's very low. The rate is very low.
Well, how about suicide?
One third was because probably because of the economic crisis.
Yeah.
1/3 was of unknown reasons, and 1/3 was because of unemployment per se. But 1/3 was of unknown reasons.
Well, do the Greek statistics permit us to zero in on suicidal ideation in 10 to 14-year-old females?
There was an increase mainly in females of young age.
Okay. Okay. So it's the same phenomenon.
But the trend
Yeah.
of increasing suicides seems to have started already since 2003, 2004, some 4 or 5 years before the economic crisis, in middle-aged males. So there are a lot of details we cannot really put in a single theory. In my opinion, what happened here, and it could be used as a model because we had extreme occasions in the society during the last decade. What happened is that during the economic growth, there was an overheating which pushed some people, let's call them hyperthymic, risk-taking people, to take too many risks, and then they commit suicide, or they were too much disappointed because they could not catch up with the running society. And then we had a different wave of suicides because of different circumstances. And then we had this glorification of suicides by the media, which was a suggestion, as you said. So I think in Greece and all around the world, we have different waves, which sometimes tend to coexist, but other times are separate.
Well, if this really is a kind of cyclic phenomenon, then you would say, well, this is just part of the cycle. But that red bar that I showed you, that enormous increase in suicidality among young females and girls, I don't think that's part of any kind of cyclical phenomenon, because this has never existed before.
This could be the phenomenon of the combined effect of survival during infancy plus anomy, which is exploding today. We have 30 years ago, we wouldn't need psychological support in our universities. Today, no university can survive without. So people in their 20s, they fail to pass exams and they need the counseling. In my era, that was we went out to get drunk. Yeah, but they need counseling, and this is not an isolated phenomenon; it's widespread. So there seems that the younger generations have horizontally some kind of reduced resiliency, psychological resiliency, and also, the army says that young soldiers today are much more physically resilient, but psychologically they're not so resilient. Even those who like the military career. So I'm thinking of a generalized change in psychological resiliency, definitely, but also in some psychological features in youngsters today.
Well, in stressful times, there is an increase in psychological resilience for sure. During the pandemic, we've seen much less suicide than before because people have been called upon to be resilient. During both the world wars, there were declines in suicide because of this increase in resiliency that you mentioned. So there are many, many circumstances that determine the overall level. But what interests me is the increase in young girls, in young women. And nobody's come up with a really good explanation for that. And I'm proposing social media use.
But you know, Myrna might know this, might explain us this much better. You know the law of initial value. If you have a very low baseline, then the increase is disproportionately high in comparison to when you have a higher baseline. So young girls had a very low suicidality rate in comparison to young boys. So the change could be disproportionately high. Not sure how, and this is so, this is embedded in the nature of numbers.
Yes, that's true. That if you have a very low status quo ante, then any increase is going to look much bigger than if you have a high status quo ante. That's true. But the increases that I presented in my talk are enormous increases. It's not just an arithmetic effect.
Myrna.
That was startling. And I don't know the reason, and I wasn't aware of that statistic, but I think it's a good idea to throw out as many theories as possible and to bring it to the attention of the public and the healthcare facilities. I did not know about that.
The
So thank
changing
you.
statistics of suicidality.
Yeah, I did not know that. And it's pretty alarming.
For sure.
The
And
interesting
I could
thing,
throw out all kinds of hypotheses, but I don't have any validity to them.
I don't have any, I don't have a picture of how things are among racial groups in the US. I know there is a very strict geographical distribution, with East versus West being completely different, California being a much different area, and also the New York City state and the Appalachian region being completely different. And this is very stable across decades, but I don't know whether this young females thing is consistent among racial groups.
That's a really good question. I don't know the answer to it either.
Because I think, I'm not sure, it's white people issue.
Yeah, they have higher suicidality than blacks and Latinos. These are the three groups. Our statistics are black, white, Latino are the three statistical groups. And this is more pronounced among whites. Yeah.
I think it's
more than blacks.
Yeah.
And is it whites of any social class?
The change is higher.
Yeah.
The change in girls is higher among whites. It's almost, I think it's not existent in Latinos.
Rates for blacks and Latinos are lower than for white girls.
I would also like to add, if possible.
Yes, Daria.
Yes, absolutely agree with Professor Edward Schotter. And we have this epidemic of suicides among Russian adolescents, mostly females. It was the game called Blue Whale, when people were gaming and exchanging information. And the first suicide was registered in 2015. And we have some countermeasures when we didn't allow our children to use phones, or it was very strict propaganda against using social media and using
Turns out to be a good idea. Very authoritarian, but nonetheless a good idea.
and so
This
and
is
many
exactly,
parents.
sorry, Daria, this is exactly the point, Edward.
Yeah.
Some people seems at least a small minority needs to be taken care of their lives, to say it in an elegant way. Freedom
Well,
is
sure.
too stressful for them.
Yeah, there's some people who thrive in an authoritarian society and others who don't. Sure.
Sorry for the interruption, Daria.
Yes, yes, I agree with everything. And you know that parents, they all were blaming internet, social media, everything. So, and we stopped with this pandemic in 2 years after some contra measures and some work with adolescents. So, and it was mostly about spread information among parents groups, among school teachers, who restricted, who then asked their children, adolescents, not to use, not to enter these groups, not to use. So it was a massive propaganda.
Good luck with that.
I don't know what's happening now actually, but it was one.
Peter
case.
has raised a hand, but Peter, before you intervene, there is a question. Why can't we notice the same increase in male suicidality if social media and influence is to blame, is to be blamed?
Well, we could use it. It would, in theory, or work, but females are much more plugged into social media than males are. So it's women, females who spend far more time on social media. It's males play computer games. That's
And
not social
also
media.
the baseline is lower in females, so the explosion is much more evident.
Well, this is a statistical phenomenon that you mentioned quite rightly, but still, the male use of social media in general terms is much less than female use.
Peter.
Well, thank you very much. It was very, very interesting, and I followed it with the greatest attention. I think it was really very important that time to compare and to try to analyze why in some countries there are suicide goes down and some rise. And it was, you know, sometimes not very difficult to explain. I asked Norman Sartorius some time ago, and he told me that there are some general tendency in the world that the suicide go down, with the exception of US and particularly. Probably you pay more attention to this problem, you investigate more deeply. But it was just before the pandemics. Now we should a little bit refresh this data. But my feeling is that I absolutely agree that the internet is a source. Development of internet is one of the main source of this suicidality. And I know that there are some special groups who provoke such suicidal behavior, and it was a great problem, and hopefully we could you know, overcome it with some strong reason. But I think also there are two aspects of suicidality in general.
Mm-hmm.
One main is biological determinant. For instance, Hungarian cases, because it was for a long time, and it was some. I remember we did a international study on biological origin of depression, and we found out that dexamethasone suppression test was different in Hungary comparatively to other country in the world from different continent. And I think this is about, I think, 70%. And about this is so-called, I don't know, genetic factor, probably. And epigenetic factor, including internet, including some other thing,
Mm-hmm.
ethnical, it's about 30% of influence. Well, once I speak about, make some hypotheses in the 80s that the Russians in some other country like Greek Irish probably people who are spent some 100 years under occupation or under dictature. They are developed their own sensitive mechanism of sensitivity to help each other. And it was confirmed, I was very surprised that it was confirmed some years ago when two Czech investigators tried to make a research within the Russian colony in US. And they called this solidarity in helping overcome the consequence of depression. They call it Soviet collectivism. I don't know, but this is interesting explanation how to overcome the depression, and as one of the possible consequence, also increase of suicidality. I think this is we should just take into consideration. One more note about the cross-ethnic difference. We just prepare for publication translation of the anthology of the Russian psychiatric text, including the old authors, and some of them are contemporary, but mainly the old one. It's complete translation into English, is ready to be published.
Right.
And one of them, it was unique because it was article of Ivan Pavlov, our famous physiologist,
Sure.
who write a special article about the suicidality of the Russians as a
Really?
Russian national sign. It was, of course, he wrote it in the 30s, I think, or even in the 20s, about 30 years ago. But it was interesting because he tried to analyze the Russian character and, as I told you, this Russian sensitivity and so on and so on. So that, in fact, I assess this problem larger than purely suicidality. Is depression as a how it's say biological and social problem from the point of view of cross-ethnic difference. Sorry to be long. Thank you.
But if you distinguish between melancholic depression and non-melancholic depression, melancholic depression has a heavy biological component.
Sure.
You mentioned the DST a moment ago. For the great majority of melancholics, they have a positive DST. And that's not true of the neurasthenic depressions. But I appreciate your comment very much.
Thank you. I agree fully with your answer. Thank you.
May I add my aspect on this?
Yeah.
Rates of depression and melancholia do not really differ among countries, or at least the differences are very, very small.
That's true of melancholia for sure.
So there is no difference in depression rates. What seems to be much different among countries and people is stress response. Stress response.
Oh, really?
And I will come to this specifically. And the DST measures stress, not depression. So stress is what is the key point here. So if you are depressed plus stress, then you are at higher risk of committing suicide, or at least it's a good theory. Now, let me give you a very simple example of how different people differ in terms of stress. In terms of physical stress, which is reaction and tolerance to cold, northern people have a much cruder response with the mobilization of brown adipose tissue, and they tolerate pain because of cold on their hands, on their skin, while us southern people have fine-tuning, less robust fine-tuning, and less explosive adjustment to cold. So there are differences, biological differences, at least to physical stressors. We don't know whether this is true also for psychological stressors, because there is no adequate research, but for physical stressors, it's almost proven. Now, a difference, what Peter said, a difference between people, let's compare Greece with the US. Greece has, let's say, a homogeneous, genetically homogeneous, more or less, people who lost because of war, famine, blah blah blah, genocide. At least half of manpower of population during the last 200 years, successive wars and whatever. At least half or 2/3. This made the Greek population more resilient, in brackets.
Survival of the fittest, in other words.
Yes. And then we have the US, who is an admixture of immigrants, more novelty seeking, more aggressive in psychological terms, more expansionists. But it's an admixture of people from around the world. To be noted that in the areas with high suicidality, west of the Rocky Mountains, these are of Central European origin, Germans and Hungarians. Now, this is an admixture, and genetics, Myrna knows that much better, but anyway, she left. We have the regression to the mean, which means that second or third generation will have more characteristics of the parent population than of the one who migrated. But I mean, different countries have much different histories and much different stress reaction.
Sure, we had the example of Hungary just a moment ago.
Daria, would you conclude?
I would only conclude with sincere and deepest gratitude to our dear professors, Professor Myrna Weissman, who was the first speaker, and dear Professor Edward Shorter with an impressive lecture, I would emphasize, so thought-provoking, and we'll be thinking here in Russia more about this.
Thank you, Daria. Thank you.
And thank you, dear Professor Kostas Fontoullakis, for managing this event, this unique project. Once again, I suppose, and people are writing that the event is excellent. So see you the next meeting. And thank you very much to Let's Study Greece for managing the event as well.
Thank you, Edward. Thank you, Peter.
Kostas, you're welcome. Thank you for inviting me. Thank you.
Bye-bye.
Bye-bye.
Bye-bye, everybody.